Hi guys, hope I'm audible. Welcome to the NEET SS 2025 Medical Group Elite Season 5 and Medical Gastroenterology are the questions that I'll be discussing at this point of time. Recently in the exam, we had posted around 25 questions. So here we will be discussing the questions and the appropriate answers. Most of the questions are based on the recent edition Harrison 22. And wherever it's little older version, I would be explaining to you guys what new could be expected in future. So right away, let's start off. I've also opened the chat box here adjacent to me to make sure that whoever are live can also ask questions parallelly. There may be a small lag, but I'll be answering the questions also simultaneously. So the first question that was asked was like this. Which of the following is a diagnostic criterion for distal esophageal spasm according to Chicago classification version 3? Options were A, more than or equal to 50% ineffective swallows with normal IRP, and option B, more than or equal to 20% premature contractions with distal latency less than 4.5 seconds. Option C, 100% failed peristalsis with elevated IRP. And D, more than 20% swallows with DCA more than 8,000. So, there are various major esophageal motility disorders and minor esophageal motility disorders. Chicago's classification is an expected question, no doubt about that. In the recent Harrison, they do not mention too much about the classifications, but the change from 22nd edition is the name has been changed from distal esophageal diffuse esophageal spasm to distal esophageal spasm. Okay, that's one thing. So, however, the subgroup criteria for different major subheadings has not been changed. We all know, and we have already discussed in various classes, that distal esophageal spasm is more like if we do an esophageal manometry of the swallows that actually occurs. Normal swallow is like this, where there is kind of swallow that occurs by relaxation of the pharynx, and then simultaneously there will be some form of relaxation that occurs in the lower part, and the entire peristalsis flows like this. In few of the patients who suffer from distal esophageal spasm, after the pharyngeal contraction, that is relaxation, the swallow starts, the peristalsis goes almost vertical. So this distance, that is from the start of the swallow to a point called a CDP, is called the distal latency. And if this is less than 4.5 seconds, is considered as distal esophageal spasm. So from a criteria perspective, there is no change. And the only one option that matches the answer is option B. Now, let's look at the answer. Yes, the answer is B. And there are various other options where option A is basically defines ineffective motility, where more than 50% are ineffective. And raised IRP with 100% failed peristalsis is basically type 1 achalasia. DCA more than 8,000 defines jackhammer's esophagus. Now, this is a famous picture which you guys should definitely know to understand the different major disorders of esophageal motility as per Chicago classification. But what you all have to remember is recently version 3 has been changed to version 4, which could be the next question that could be expected. So it is slightly modified. So version 4 is the new one. Okay. Here there are some changes from the previous one. One, you have a primary position, and also you do few things in secondary position. There is more emphasis on few newer tests like abnormal timed barium and FLIP studies to diagnose EGJ outlet obstruction. Okay, guys, and fine-tuned changes in the definition, like say ineffective peristalsis initially was 50%, but now you call it more than 70%. Okay, so these little changes are something which they might expect you, especially for NESS goers. But NEET SS also they may test if you guys know it or no. So there's a difference between version 3 and version 4. Version 4 is the newer one. Here the criteria for various problems like say achalasia, EGJ outlet obstruction, absent contractility, distal esophageal spasm, hypercontractile esophagus, and ineffective esophageal motility. Okay, these things are slightly different when you see version 4. Okay, so what the changes starts, and the reason for the change has also been mentioned here. You guys can go through detail. You can guys can take a screenshot later. So in the type 3 achalasia, they had said that initially failed peristalsis was included, but the recent fourth one includes a terminology of even supine position, and they say absent peristalsis. So absent peristalsis helps in having a more restrictive criteria. In a similar way, criteria for EGJ outlet obstruction symptoms has been added. The same way, even for distal esophageal spasm, symptoms must be added along with the criteria, and even for jackhammers, you need with symptoms. So if a patient has manometric abnormality but no symptoms, it doesn't come under distal esophageal spasm. So these are some fine-tuned changes. So you guys can go through version 4 for being much more updated. Okay, great. So now we are clear that the criteria for distal esophageal spasm, which was initially called as diffuse esophageal spasm. Okay, this name has been changed to distal, as the problem is mainly in the distal part. And even if you see 21st edition of Harrison and 22nd edition of Harrison, this name has been updated. Okay, fine. Question number 2. A 55-year-old male presents with progressive dysphagia to solids and liquids. He has no history suggestive of non-esophageal cause. Apogeoscopy with biopsy shows no structural abnormalities. What is the next best step in the workup? Option A, start PPI empirically. Option B, ambulatory pH impedance monitoring. Option C, high resolution manometry. Option D, CT chest with contrast. Okay. So this is again a question to test your knowledge. Whenever a patient has dysphagia, mechanical cause has been ruled out, you should think of motility causes. Best test to go ahead with motility cause is high resolution manometry. So option C would be the best answer for this particular question. Now let's look at the answer. Yes, option C is the one. As per simple logic, if you want to evaluate motility disorder in a patient with dysphagia, you have to go ahead with high resolution manometry to know whether it is any major motility disorder or comes under minor motility disorder after ruling out structural causes. Question number 3. Which of the following does not cause an increase in serum amylase level? Option A, pancreatitis. Option B, lungs. Option C, renal failure. Option D, cardiac failure. So we all should know that a rise in serum amylase in itself is not diagnostic of pancreatitis. You need a triad of symptoms. You need raised amylase or lipase more than 3 times upper limit of normal, and or imaging suggestive of pancreatitis. Okay, so there are 3 points to remember. That should be at least two should be positive for you to start diagnosing pancreatitis. Okay, now in pancreatitis, we all know amylase is raised because of acinar cell injury. Now, even in lung tissues, the tumor cells can secrete amylase, so it can increase. In renal failure, because the amylase does gets excreted less, amylase can increase. So the best answer would be cardiac failure. Okay. So this is again from Harrison. There is a beautiful table which tells the different causes of hyperamylasemia. So you have pancreatic causes, you have non-pancreatic causes where renal fail insufficiency is one of the cause, and you have other abdominal causes like biliary tract diseases and other intra-abdominal disease like perforation or peptic ulcer disease, all of which can lead to raised amylase. That is why amylase is somewhat non-specific, and we suggest you guys to do lipase to be, which is a more specific test for pancreatitis. Okay, guys. So again, a question which you can expect in your exams. Question number 4. 29-year-old man presents to the emergency department with acute painful swallowing. So painful swallowing is important. He reports accidentally ingesting a radiopaque foreign body earlier that day. He has no history of caustic ingestion. What is the next best step in management? Is it you start PPI and observe? Is it B, upper GI scopy immediately? Is it C, CT thorax with the oral contrast? Or is it D, high resolution manometry? So if you guys start thinking for this question, see, patient has a foreign body inside. So you can't just give PPI and give symptomatic management. Second, a performing upper GI scopy is important to remove the foreign body, but here the patient has come with painful swallowing. So before doing an upper GI scopy, you have to rule out complications like perforation, for which you have to do a CT scan with oral contrast. So C is the best answer. D, high resolution manometry is basically an evaluation for motility disorder. Here, there is a clear-cut structural foreign body which is in the esophagus, which needs evaluation for complication followed by removal. So D is not the answer. So answer is C, CT with oral contrast. So basically, it is done to localize the object and to assess the complications before doing an endoscopy. So that's again important. So whenever somebody presents with odynophagia and there is history of ingestion of foreign matter, you have to evaluate accordingly, especially if there is also a recent history of radio opaque foreign object. You have to probably go ahead with CT scan with oral contrast to rule out if there is any complications. Now this is important, guys. Okay, so other options I've explained why they are not the answers. Let's go to question number 5. 38-year-old woman, she feels there is persistent sensation of lump in her throat. She denies history of difficulty swallowing the solids or liquids. The sensation is present irrespective of swallowing, so that it's not related to swallowing at all. Otherwise, she's healthy and has some anxiety and obsessive tendencies. What is the most likely diagnosis? A, Schatzki's ring, B, esophageal stricture, C, globus pharyngeus, and D, Zenker's diverticulum. So if you guys have a basic idea about different causes for esophageal dysphagia, you would be able to tell this. Schatzki's ring presents with dysphagia, esophageal stricture, the same thing. Globus pharyngeus is more descriptive of the condition that she has, and Zenker's diverticulum more presence in elderly with halitosis and regurgitation. So the best answer is C, to describe a foreign body sensation of lump in the throat and not associated with swallowing. Okay, so the best answer is globus pharyngeus, and yeah, it is sensation of fullness or lump in the throat, often unrelated to swallowing, associated with anxiety, OCD, or GRD, and does not reflect true dysphagia. Okay. Next, question number 6. Which of the following is not a part of bedside index of severity in acute pancreatitis, that is BISAP score? This you should know. Options are impaired mental status, B, body mass index, C, SRS, and D, pleural effusion. So you would know by now that you should know important criteria in acute pancreatitis at admission and at 24 hours and little later. and should be able to evaluate whether the patient needs admission or not. And one of the important criteria is BISAP criteria, where B actually stands for BUN, I for impaired mental status, S for SIRS, age, A for age, and P for pleural effusion. Okay, so this criteria has 5 parameters and helps us to assess the severity and the need for admission in case of patients who present with acute pancreatitis. Okay, so they can predict if 3 or more of these factors are present, it is associated with substantial risk of in-hospital mortality. There are also other scores you can parallelly read about it. Next is a 44-year-old man presents with heartburn, chronic heartburns, undergoes an upper GI scopy, and this reveals a mucosal break of more than 5 mm in length, and they are not bridging between the folds. So according to Los Angeles classification, what is the appropriate grade of reflux esophagitis the patient has? Is it Los Angeles grade A, grade B, grade C, and grade D? The straightforward question, if you know how to analyze the pictures. So again, this is also there in PG curriculum and in NEET and in NESS, where I've described the different pictures of endoscopy and how to diagnose based on what we see in the pictures. So Los Angeles classification, one of the important classifications that we use to grade the GERD, that is erosive reflux disease. And this is a classification where A stands for mucosal break less than 5 mm and confined to mucosal folds. B is more than one break more than 5 mm but confined to mucosal folds but not bridging between folds. C is where it's bridging between 2 or more folds but is less than 75% of circumference, and D is more than 75% of esophageal circumference. This is a beautiful picture to explain the same. When you do an endoscopic view, this is how it will look. Just plain mucosal break less than 5 mm is grade A. If it is more than 5 mm confined to a single fold with now bridging between each, it is B. If it is continuous between 2 folds or more folds but less than 75%, it is C, and if it's almost circumferential or more than 75%, it is grade D. Question number 8. In a patient with PPI refractory regurgitation and documented abnormal esophageal acid exposure, which of the following intervention has the most benefit as per clinical trial? So, the patient has PPI refractory regurgitation. There is a documented abnormal esophageal acid exposure. Now, how do you measure esophageal acid exposure? You use 24-hour impedance study. 24-hour pH plane or with impedance study, we can measure this. If patient is persistently having problem, which of the following will benefit him most? Is it addition of baclofen to PPA or doubling the dose of PPA or anti-reflux surgery or hypnotherapy? Now, hypnotherapy is for functional heartburn or something where there is no actual raised abnormal times. PPI refractory, you define it when you have already tried with appropriate dosing of PPI. So the best answer out of ruling out is also Nissen's fundoplication. However, as per data, there are newer things coming up, but there were NEGM studies in 2019 and also trials like Lotus trials which were done before. And most of them have consistently told that if a patient has refractory PPI resistant reflux disease which is diagnosed, then the best test or the best therapeutic procedure at this point of time is anti-reflux surgery. Example, laparoscopic Nissen's fundoplication. Nissen's fundoplication is where you do a 360 degrees. Okay, so this is superior to just using medications. Okay, the other options I have ruled out easily. Okay, yeah. Next is question number 9. A 17-year-old male with ulcerative colitis on mesalamine in remission and presents with fatigue, anorexia, and right upper quadrant pain. ALP is elevated. Very important. So ulcerative colitis with ALP elevated, total bilirubin is raised. Normal AST ALT. Ultrasound shows mild hepatomegaly. There are no stones. Viral markers negative. MRCP shows the following findings. What is true about this condition? Now, you guys should be able to identify the condition. Usually with MRCP with raised alphas, generally is a PSC. You find that beading pattern, stricture followed by beading, stricture followed by beading, which is seen here, especially in the intrahepatic area. So this is nothing but PSC. There's no doubt about the diagnosis. Now, the options they are asked is which among the following is true? Which among the following is true? It occurs in 50 to 75% of patients with UC. Okay, let's decide about it later. It is more commonly associated with Crohn's disease than ulcerative colitis is wrong. It is more associated with ulcerative colitis. It is associated with decreased risk of colon cancer is again wrong. They are associated with increased risk. Okay. D, it can develop even after colectomy is again true because of the autoimmune nature of condition and immune dysregulation. Even after colectomy, PSC can occur. So the best answer, if you don't know anything about the numerical data, is 50 to 75% of patients with UC. But however, from numerical perspective, you guys should know this much, that what is the relationship between IBD and that of PSC. Okay, almost 5% of ulcerative colitis or 3% of Crohn's disease will have PSC. On the other hand, almost 75% of PSC will have IBD. This is just vague now numericals for you guys to remember. So this much data you guys should know. So here the correct answer is it can develop even after colectomy is actually true. So the first three statement is false. Okay. Sorry. So the question is which is true. Okay. So it occurs in 50 to 75% of patients with UC is wrong. It's actually the other way around, where in UC or in IBD, you have very small single digit numbers having PSC. Whereas if a patient has PSC, them having kind of IBD is higher, almost 50 to 75%. So the best answer is it occurs even after removing the colon is actually true. Okay. Yeah. So this is the explanation. PSC, there are basic stuff which you guys should know. It is basically a chronic progressive cholestatic disease, which in turn in due course can even lead to cirrhosis. These guys are more seen in patients with UC, and you need to document alkaline phosphatase being elevated in a case of IBD, which should trigger you to do an MRCP and the diagnosis will be picked up. Important numericals also fact to know is patients with PSC have higher risk of developing cholangiocarcinoma and colorectal cancer also. And the data I've already explained on how to derive or approximate towards the answer if you know the relationship between IBD and PSC. What you guys have to know is a very small percentage of patients with IBD will have PSC. Whereas if you see the cohort of patients presenting to you with PSC, almost 50 to 75% of patients will have IBD. Okay, that relationship you guys should know. Okay, next question is 34-year-old male presents with progressive dysphagia with and recent episode of food impaction. Endoscopy shows all these rings and furrows, which obviously by now you should know what it is. This is feline esophagus, and some exudates are seen. This is also a picture showing raised eosinophils seen in the stratified epithelium of the esophagus. This is esophageal esophagitis. So option they have asked us, what are you going to do? A, start the patient. The question is, what is the best initial step in management? Best initial step in management, would you give a systemic steroid, or would you dilate the patient, or would you give a trial of PPI, or would you start off with empirical elimination diet without biopsy? Okay. So you all should know that almost close to 50% of patients with eosinophilic esophagitis have PPI responsiveness. So the first option or the first line of treatment would be a PPI. However, recent evidence 2025 ACG guidelines says you can decide based on multidisciplinary decision on whether to give a trial of PPI or start with systemic corticosteroids or empirical elimination diet. Okay, so however, till now the best option as per at least Harrison, it would be to go ahead with PPI trial, as almost 30 to 50% of patients have documented reduced inflammation and are used to pick up those few patients who are PPI responsive eosinophilic esophagitis cases. Okay. So yeah, this is a table which is based from ACG guidelines on eosinophilic esophagitis. And the first line option should be a shared decision making where you decide between PPI, dietary therapy, and topical corticosteroids. Okay. Then comes the second line, which could be alternatives. That is, you could use for patients who are not responsive to PPI, who can switch to diet or topical steroids and vice versa. Biological therapy and endoscopic therapy and other maintenance therapies are generally discussed later. Okay. So, however, in this question, what you have to know is systemic corticosteroids is the one which is used. That's not the first line. Topical corticosteroids is what is used. Now that's again an important point you guys should know. Okay, so yeah, so these are the different options. Now question number 11. Question number 11, 58-year-old male presents with early satiety and epigastric discomfort. Endoscopy shows an ulcer on the lesser curvature of stomach. Biopsy shows foveolar hyperplasia, epithelial regeneration, and lamina propria edema, and negative for H. pylori. What is the most likely mechanism? Is it increased basal output due to H. pylori? Wrong. They've clearly told H. pylori is not seen. Chemical gastropathy through NSH is very, very possible because that's the one which presents with less inflammation but foveolar hyperplasia. Zollinger-Ellison syndrome usually will not have a single ulcer, they'll have multiple ulcers, especially towards the duodenum. And bicarbonate depletion in duodenal bulb is not something which is which causes gastric ulcer, it more causes duodenal ulcer. So the best answer is B. Okay. Yeah. So histological pattern of chemical gastropathy, that is NSAID induced gastric ulcers, is foveolar hyperplasia, edema, and epithelial regeneration. Other options can be easily ruled out, like H. pylori was negative in this case. There was not many inflammation present. Zollinger-Ellison would usually present with multiple duodenal ulcers, and option D would actually contribute to duodenal ulcer and not gastric ulcers. Next question number 12. Which among the following statement regarding gastric and duodenal ulcer is incorrect? Okay, there was incorrect statement. So option A, duodenal ulcers are most commonly associated with increased acid secretion than gastric ulcers, which is true. Gastric ulcers typically cause pain that worsens after meals is also true. Malignancy is more commonly associated with duodenal ulcer than gastric ulcers is false. We all know that duodenal ulcers have lesser chance of malignancy. Gastric ulcers can be malignant and hence you have to take biopsy. Biopsy is recommended in gastric ulcers to rule out malignancy is true. So the option C, if you just knew about one fact, either C or D, you would be able to rule out what's the incorrect option. Okay. So malignancy is more commonly associated with duodenal ulcer than with gastric ulcer is the incorrect statement. That's the correct answer. Gastric ulcers have higher risk of being malignant, so biopsy is mandatory. Duodenal is rarely associated with these. Okay. Duodenal ulcers are caused by increased acid secretion than gastric ulcers. It's a true statement. Gastric ulcers pain worsens with after meals is true, whereas duodenal relieves after food intake. Biopsy is recommended for gastric ulcers to rule out malignancy. Now, this is a comparative table between gastric ulcers and duodenal ulcers. Duodenal ulcers occur in younger people. More males get affected. Usually in first part of duodenum, malignant potential is very rare, usually related to increased basal and nocturnal acid secretion. Relieved by meals becomes very important. There's a strong association also with H. pylori. NSAID association is also there, but NSAID more commonly causes gastric ulcers. Okay. So biopsy is almost mandatory in gastric cancers. Question number 13. Which of the following non-invasive test that is preferred to confirm eradication of H. pylori after treatment? Is it stool antigen, biopsy urease test, or urea breath test, or a serum antibody test? Now, antibody test is ruled out because it can never tell you whether it is past infection or current infection. Biopsy urease test can tell you, but again, doing an endoscopy is invasive test, so that they've asked for non-invasive option. So among the option of stool and urease breath test, The test with better accuracy is urease blood test. So C would be the best option here. So C is the best option here, and the reason being that it is high sensitivity and specificity compared to the other non-invasive tests that we have. So the urease blood test has higher sensitivity and specificity. Okay. Yeah, compared to even stool antigen test. The closest option to this is stool antigen test. Urease blood test has somewhat higher accuracy. Okay, that's something which we should know. Question number 14. A 14-year-old man presents with symptoms of upper abdomen pain, early satiety, upper GI confirmed duodenal ulcer. Testing confirms active Helicobacter pylori infection, and regional antimicrobial surveillance says that clarithromycin resistance is at 18% and metronidazole is at 5%. What's the most appropriate initial eradication regimen for this patient? Clarithromycin based triple therapy A. B is PPI, amoxicillin, metronidazole triple therapy. C is bismuth containing quadruple therapy, and D is levofloxacin based triple therapy. So the first line in this patient where clarithromycin resistance is high, definitely you can't use A. Option B can be tried as a triple therapy. Bismuth containing quadruple therapy can also be tried. Levofloxacin based triple therapy, which has levofloxacin instead of clarithromycin, can also be tried. But here they've asked which is the best to start off and not complicate things. So the best would be just to replace clarithromycin with metronidazole. That is option B, because metronidazole resistance is just 5%. Okay. So now let's look at the how to approach with the answer. Whenever you're dealing with a high clarithromycin resistance and there is low metronidazole resistance less than 5%, as in this patient, amoxicillin metronidazole triple therapy is preferred. If there is dual low resistance, that is low dual clarithromycin and metronidazole resistance both less than 15%, you have multiple options. You can try triple therapy, you can try concomitant therapy, bismuth quadruple therapy. If clarithromycin resistance is high and you have metronidazole resistance also high, then you only option is bismuth quadruple therapy. Okay, so you guys should know about the different options for Helicobacter pylori regimen. Patient first line of medication when they come that we use is clarithromycin based triple therapy. If there is penicillin allergy, then the best option we have is bismuth quadruple therapy. If the patient has clarithromycin resistance or the area where we have done the test has significant clarithromycin resistance of more than 15%, instead of clarithromycin, we can put metronidazole triple therapy. Okay. The various other options, but this is the way we go about it. Thank you. So question number 15. A patient experiences 5 documented episodes of small intestinal bacterial overgrowth within the past 12 months despite successful initial therapy. Which of the following prophylactic antibiotic regimen is most appropriate? Is it rifaximin every week for 3 days every week, or is it any effective antibiotic for 5 to 10 days every 2 to 4 weeks, rotating agents every 2 to 3 months? This sounds the best for refractory cases. Okay. Yeah. See, metronidazole for 6 months, not recommended. Monthly neomycin 1 gram single use is not recommended in these kind of recurrent cases. So cyclical antibiotic therapy is preferred in recurrent cases. So best option is option B. Patients with more than or equal to 4 SIBO recurrences per year benefit from prophylactic antibiotic courses given 5 to 10 days every 2 to 4 weeks with rotation of antibiotic classes every 2 to 3 months to reduce the resistance and maintain efficacy. Okay, so I think there is a question now. Yes, Harrison says bismuth quadruple therapy. I agree with you, but among the options, what you can try is the question that I've been asked here. Bismuth quadruple therapy if there is penicillin resistance. Okay, Now, some areas, okay, if you see guidelines, even metronidazole resistance is here. The metronidazole resistance is less, is what they are telling. So you can give metronidazole. That could be the first option among the options given in this particular question. Okay, Dr. Sharad. Yeah. So when it comes to more than or equal to 4 SIBO recurrences, prophylactic antibiotic courses can be given, and rotational antibiotic class between different antibiotic classes can reduce resistance and maintain efficacy. Okay, so the initial antibiotic therapy that we generally give in a hydrogen predominant overgrowth is rifaximin. In methane predominant overgrowth, we would also put the patient on neomycin along with rifaximin. And alternative antibiotics, there are many like Cipro, Metro, Tetra, Amoxiclav, and neomycin. For recurrent, what do you manage? So early recurrence, which occurs within 3 months, you can repeat the same or alternate antibiotic course. Late recurrence, antibiotics is only required only if the blood test is positive. Elemental diet is usually very difficult to follow, and it is generally given in case where patients cannot tolerate antibiotics or fail to respond to antibiotic therapy even after 2 times. Okay, so prophylaxis is generally recommended for anybody who have more than 4 SIBO episodes per year. Any effective antibiotic for 5 to 10 days every 2 to 4 weeks, and rotating between antibiotic classes recommended. Okay. Now, prebiotics, low FODMAPs or statins, though are in studies as therapies recommended for SIBO, are just adjunctive and or cannot be used as monotherapy because they are ineffective. Okay, guys. Yeah. Next question number 16. A 35-year-old woman presents with intermittent fatigue, bloating, iron deficiency anemia, and group vesicles on the leg. She has been following a strict gluten-free diet for the past 3 years due to cultural reasons. Serology tests, including TTG, IgA, and total IgA, are currently negative. Her mother has been diagnosed with celiac disease. What's the most appropriate next step in management? So, if you want diagnosis in a patient with gluten-free diet, you can have TTG negative, you can have total IgA, which may be, false, this thing. So on somebody with gluten-free diet already, and if you want to establish a diagnosis, the best among this option would be option A. If it is performed duodenal biopsy immediately, it can still be negative. Begin the therapy for somebody to begin corticosteroid therapy when the patient is actually, um, you know, on strict gluten-free diet already and still having symptoms. First you have to establish the diagnosis. So it's not yet established, so better don't give steroids, and steroids are given only for refractory cases. Third, ordering a HLA DQ2 DQ8 genetic test is the best, because this can diagnose irrespective of the gluten-free diet is there or not. So HLA DQ2 DQ8 is the best test because it has a high negative predictive value. Diagnose functional gastroenteritis disorder is not relevant in this particular question. So in this patient who is already on a gluten-free diet, serological testing may yield a false negative results due to absence of antigenic stimulation. So HLA typing is useful in this particular context. A negative result effectively excludes celiac disease, but if it comes positive, then we need to do gluten challenge followed by a repeat serology or biopsy. So that's important. Okay. So you guys can go through this beautiful table. Whenever there is a clinical suspicion, by chance patient is already on gluten-free diet, you can start off with HLA DQ8, and if turns positive, we can plan for gluten challenge. Okay, this is a beautiful table you guys can follow, which is from ACG guidelines 2023. Question number 17. Which among the following diagnostic tests is considered gold standard for confirming steatoria? Okay, but again, chapter malabsorption. Options are Sudan 3 stain on spot stool sample. This is good quality quantitative test, but then it's not a gold standard. 24-hour stool weight measurements is also not a gold standard. 72-hour fecal collection after 100-gram diet is the gold standard. Okay. Elastase concentration, again, cannot quantify it. So these are all qualitative tests. Quantitative best test is 72 hour fecal fat collection after 100-gram fat diet. Okay, so this is most accurate test. Usually in health, the stool volume or weight is less than 200 ml or less than 200 grams respectively in 24 hours. Collection should be done, and 72-hour collection after giving a high fat diet, and if the stool excretion is more than 7% of the dietary fat, suggest malabsorption. This is the best quantitative test that you should know. Okay, guys. So next is question number 18. 35-year-old male presents with chronic diarrhea, weight loss, intermittent abdominal pain. Which among the following is least likely to be associated with Crohn's disease? Option least likely to be associated with Crohn's disease. Okay. So option A, perianal involvement in 1/3 of patients, transmural inflammation. Option C, continuous colonic inflammation with granular mucosa is suggestive of ulcerative colitis. Continuous word doesn't go with Crohn's disease. Presence of ASCA antibodies. Okay, so that's again suggestive of Crohn's. So ABC is for Crohn's. C is the best option, which actually is incorrect, with least likely with Crohn's disease. So Crohn's and ulcerative colitis differences will be definitely asked, if not in main exam, at least in interview round. Very commonly asked question. Please know the differences between Crohn's and ulcerative colitis. Crohn's have a lot of skip zones, can involve anywhere in the GI tract, whereas ulcerative colitis, as the name suggests, is usually only in the colon. It is more continuous and as associated with P. anca sometimes, and is superficial, only involve mucosa and submucosa, unlike Crohn's disease. Question number 19. In the management of mild to moderate extensive ulcerative colitis, a patient is on once daily standard dose mesalamine but has persistent symptoms. What is the next recommended step? Switch to mesalamine suppository, increase high dose mesalamine with rectal 5-ASA. C is add oral prednisolone immediately, start biologicals therapy. So among these particular options, what you should notice is it's for mild and moderate. But and also remember the word extensive ulcerative colitis. It is not left-sided or it's not proctitis. Okay, it is extensive ulcerative colitis. So once a day mesalamine is suboptimal. If there's no response with that, you have to increase to high dose mesalamine along with rectal 5-ASA. So again, for mild to moderate, this is how we approach the case. Whenever there is ulcerative colitis, we have to know whether it is just proctitis or proctosigmoiditis or extensive. If it is extensive, first is once day mesalamine. If ongoing disease activity, we have to go for high dose mesalamine with rectal 5-ASA. Okay. However, remember this is an extensive disease. If it is proctitis, we just start with mesalamine suppository, and if convenience based you want, you can start with oral 5-ASA. Okay, so for different types, you have slightly different this thing. Suppose if it is proctosigmoiditis, suppository may not be enough. We may even go for enema. So for this question, you have to follow this particular line. Okay, so best option in this particular question is to increase mesalamine orally and also give rectal 5-ASA. Question number 20. 32-year-old women has recurrent abdomen pain, altered bowel habits for the past 8 months. There is hard, lumpy stools with bowel movements less than 3 times per week. She is diagnosed with IBS-C. She has already been counseled and given dietary modifications and exercise. Which among the following pharmacological agent is most appropriate to initiate next? Okay. First is loperamide. For see, she already has IBS-C. Now you have to remember, for IBS-C constipated type, you have to give dietary modifications with high fibers and other things, conservative followed by medications. So loperamide will increase constipation. It's not recommended here. It's more for IBS-D. Lubiprostone can be tried. Rifaximin is for IBS-D first. Elaxadolin again is for IBS-D. So you guys should know how do we manage patients with IBS. So there are pharmacological management and non-pharmacological management. Pharmacological management based on the symptoms. First, we give for constipation drugs like psyllium, anti-secretory agents. Then comes laxatives and maybe even 5-HT4 agonist. So from this option, lubiprostone is the best answer for this particular question. Rest of them are usually drugs which are used for IBS-D like loperamide, rifaximin, Okay, so we could give a trial of bile acid diarrhea, alexadolin, and 5-HT3 receptor antagonist based on different subgroup categories. We have different inclusion and exclusion ways to decide on why we have to give this particular pharmacological medications. Okay, so yeah, so it's little counterproductive, especially when you think of counterintuitive when you think of IBS-D. Actually, you using some antibiotics like rifaximin. It is there because of the effect on microbiota. IBS-D is where you actually give antibiotics. Okay. Question number 21. A 48-year-old male with alcohol use disorder presents with confusion, gait instability, and ophthalmoplegia. So by now you should know what the diagnosis is. He reports poor dietary intake and consumes alcohol in place of meals. On examination, is disoriented, nystagmus and ataxia is present. You give dextrose for hypoglycemia, following which symptoms worsen. Which of the following explains the mechanism for thiamine deficiency? Yes. They only mentioned it is a thiamine deficiency, which is good. So they've asked for mechanisms. Increased intestinal absorption thiamine is obviously will not explain this thing. Impaired thiamine absorption phosphorylation with increased urinary losses is the best answer. Excessive dietary thiamine intake leads to competitive inhibition is wrong. Thiamine accumulation in hepatic stores due to impaired utilization is again wrong. This is basically thiamine deficiency. The word this is basically, even if you would not know, just knowing English and trying to understand what's the options are trying to mean and group things which are together and things which are odd can already give you the answer. What you guys have to know is thiamine deficiency is because of various causes. In alcoholism, first there is reduced intake, then there is reduced absorption, third there is reduced hepatic conversion to active coenzymes, fourth there is increased urinary excretion because of the alcohol's diuretic effect. Because of all this, thiamine deficiency is there, and active form of thiamine is TTP will be less, which can precipitate encephalopathy and neurological manifestations because of lactic acidosis, which we typically call as Wernicke's encephalopathy. Okay, so please give thiamine in these kind of patients. Don't just give dextrose. Question number 22. Which vitamin in high doses may protect against oxygen-induced retrolental fibroplasia, bronchopulmonary dysplasia, and intraventricular hemorrhage of prematurity? Sorry, the answer is already in the page. It is vitamin E. We all know that vitamin E can toxicity can lead to these symptoms. Remember, nutrition is an important topic, especially a lot of questions could be asked with respect to the nutrition, the vitamin, multivitamins, the deficiency of vitamins, symptomatologies, and excess vitamins. Now, vitamin E is an antioxidant that protects cellular membranes against oxidative injury. In premature infants, high oxidative stress from supplemental oxygen predisposes to lateral fibroplasia, bronchopulmonary dysplasia, and intraventricular hemorrhage. High dose vitamin E supplementation has shown to benefit this particular complication. So high dose vitamin E supplementation actually is beneficial in because of its high antioxidant effect in preventing high oxidative stress because of supplemental oxygenation in premature infants. Okay. Similar thing, you also should know that vitamin K prevents hemorrhagic disease in newborn, however, not protective against oxidative neonatal complications. Okay, they are again related, where you supplement to prevent few complications that can happen in neonates. Okay. Question number 23. 32-year-old male presents with infertility, testicular atrophy, and delay and developmental delay. He has history of chronic occupational exposure to glass and ceramic factory. Which elemental toxicity is most likely responsible? Again, you should know about toxicity sometimes and know about basic around there are 10 important minerals like this. Here actually boron would be the best answer if you knew the symptomatology of what boron toxicity could lead to. Now, boron toxicity is associated with the glass factories, and these can lead to developmental defects, male sterility and testicular atrophy. Okay. In the same way, copper toxicity can lead to hepatic failure, selenium toxicity can lead to alopecia, nail changes, garlic odor in breath, and zinc toxicity can lead to pulmonary fibrosis. And so you should know important terminologies for each of these ones to crack these particular questions. Question number 24, 50-year-old women presents with pruritus for 8 months. Alk phos is elevated to 650, GGT is elevated 180, so we know it is a liver cause. ALT is borderline elevated, ultrasound is normal. What is the next best test? So pruritus is there and it is cholestatic. Okay. So what would you do next? Is it ceruloplasmin? Are you suspecting ceruloplasmin, MRCP or ERCP, HbS-AG or alpha-1 antitrypsin? Cholestatic jaundice, you should evaluate for things which can present like cholestasis, like take a drug history. Usually you won't think of Wilson's disease, you won't think of alcohol, of hepatitis B or other hepatitic causes because they call hepatocellular injury. The best answer would be B, to rule out obstructive causes for this one. So always remember guys, when there is a chronic history and you are having cholestatic pattern, you should take a thorough drug history. Please rule out PBC. Pianca can be sent. Ultrasound and MRCP are the directions to go for chronic cholestatic syndromes. Okay, so this is again a good question from Harrison recent edition. The last question is question number 25. 9-year-old child presents with recurrent episodes of jaundice. It's a recurrent episode of jaundice and pruritus lasting several weeks and complete resolution in between the episodes. GGT is normal and is asymptomatic but raises during the attack. Genetic test reveals ATP8B1 mutation. Which among the following syndrome best fits the description? Remember, PFIC1 and PFIC3 are progressive conditions. Here clearly it is an intermittent problem. Okay, first point. Second, yeah, so it is definitely BRIC, which is the answer. Could it be Dubin-Johnson syndrome? Dubin-Johnson syndrome is more of a conjugated hyperbilirubinemia. Patients do not have any symptoms, including pruritus. They just have icterus. That's all. Okay. And there, what they generally try to look for is about pigmented liver are the kind of question they will ask. Okay. BRIC, an important table where closed differentials have been mentioned in this table. So what you guys have to know is PFIC1 and BRIC1, both of them are caused by ATP8B1 gene defect, which codes for FIC1 protein. Here the question, there were clear history of episodic problems in a young child. So this suits the answer best. Okay. But also remember PFIC2 and BRIC2 is caused by ABCB11. Okay. Remember Roman number 2 looks like 11. So ABCB11. Okay. So there are various tricks to remember this, which I've again discussed in classes before. Okay. Yeah. So these are other options. PFIC1 is not an option because it presents in infancy and early childhood and it's progressive condition. PFIC3 is having high GGT again and is caused by ABCB4 and MDR3 mutation. Dubin-Johnson is a cause for conjugated hyperbilirubinemia. It causes lifelong mild jaundice, pigmented liver. There is no pruritus or other symptoms of cholestasis here. Okay. So these are the questions for the current elite session. Hope you guys enjoyed the questions. Questions were quite simple and there was a mix, but majority of them were from Harrison 22nd edition. So soon we'll wait for the next Harrison 22 updates. Thank you guys. If you have any doubts, please ping me on my WhatsApp number and you can also come online and as of now, there are not many questions. One question has been answered and yeah, that's about it. Thank you guys. Thank you for the time.